capsule defect. So here, from the start, I will not go for hydrodissection. This is the start of anterior axis. And now, can you see this is a very large defect? If I go for hydrodissection in this case, I will lose the lens totally into the vitreous. مجرد ما هعمل irrigation aspiration, this lens totally will be inside the vitreous, which increases later on inflammation in such an eye. See how large the defect is? Extremely large defect. Irrigation aspiration, I should go for very meticulous irrigation aspiration in order to decrease the lens epithelial cells that may cause later on posterior capsule opacification. A very important step, which is extremely important, which is polishing the back surface of the anterior capsule. This may be not that important in adults, but it's very important in children. You have to remove all lens epithelial cells. Can you see here? This is cleaned, and this is not yet cleaned. It looks like a ground glass opacity of the anterior capsule. You have to clean it meticulously. Here, this part is cleaned, and this part is not yet cleaned. It has to be polished, and you should have a very good microscope with a very high resolution and perfect optics in order to see the lens epithelial cells. These are lens epithelial cells that are microscopic, that have to be removed, and the anterior capsule should be crystal clear like that. Why do we go for polishing of the back surface of the anterior capsule? In order to have a crystal clear anterior capsule after surgery. Why? Because if you don't go for polishing, this will be the picture. Extensive fibrosis of the anterior capsule like this. If you want to go for retinal exam in such a baby, for a peripheral retinal exam, it's going to be very difficult. If he develops retinal detachment later on, it's going to be very difficult to proceed with surgery. And sometimes the capsular phimosis is so severe, affecting the vision. And in such a case, this actually a very good phacosurgeon, an adult surgeon, and he did the cataract surgery in a child. He did it like as if he is doing an adult surgery. What the end? Severe capsular phimosis of the anterior capsule and secondary cataract, leaving the child in very dense amblyopia, and of course we have to go for secondary surgery. And I will show you an example that the lens epithelial cells is very aggressive. Look, we did anterior and posterior axis and polishing, and this was a baby 6 months old. And vitrectomy, IOL implantation inside the capsular bag. 6 months after surgery, what happened? The lens epithelial cells did grow over, it came out to the anterior axis, and it did grow over the anterior surface of the IOL. See how aggressive the lens epithelial cells? And then we had to go again to clear the visual axis. But it's a very simple surgery to aspirate the lens epithelial cells to clear the visual axis. Despite, can you see this is the primary surgery, anterior axis, posterior axis, and IOL inside the back. Posterior capsular axis. In such babies, again, how to proceed. This is a very important step. You don't go with a cystotome and enter like that and puncture the posterior capsule. You will definitely get the anterior vitreous face with you. And you will have the vitreous into the anterior chamber, it will pop, and you will do nothing. How can we proceed step by step? See, this is the tip of the cystotome. You go for hooking to hook something, hooking like that, trying to hook the posterior capsule, it's being hooked, and then tenting, you elevate it anteriorly, like this, and then tearing, making a triangular tear. If it is a triangular tear, it is a perfect step. It means that you did tear the posterior capsule without damaging the anterior vitreous space. If you have a rounded opening, it means that you did damage the anterior vitreous space, and the vitreous did bulge from it. Again, this is another case, a perfect triangular tear. Then, with a viscoelastic, don't go into this hole. Just at the edge of the puncture, you inject viscoelastic, because you may damage the anterior vitreous space with a cannula. Here, injecting into the Berger space. Again, if you see this halo, then you are in the right space. You are in the Berger space between the posterior capsule and anterior vitreous space. And now it is very simple to proceed with the posterior axis in the conventional way. The aim is to have a 5 mm axis and a 4 millimeter posterior rexus. Anterior vitrectomy. Many surgeons put the IOL inside the bag and then go for the vitrectomy from behind. It's very difficult. And many surgeons do implant the IOL inside the bag and then go from behind the IOL to perform the vitrectomy. Again, it's a very difficult surgery. And then deposit the IOL like that. A very simple procedure is after performing posterior axis, you perform the anterior vitrectomy from the anterior approach and implant the intraocular lens inside the capsular bag between the anterior and posterior axes. How can we go for vitrectomy? First, we perform dry vitrectomy like this. Why? In order to prevent prolapse of vitreous into the anterior chamber. Can you see here? The irrigation is outside. And then you introduce the irrigation and perform vitrectomy with the tip directed backward and the tip then directed forward. You should take care that the posterior axis, can you see this peak? It means that there is a vitreous strand coming out going to the wound. You have to clear this. Immediately enter again the cutter and remove the vitreous in order to have a perfectly rounded posterior axis. So what is the extent? Are we going to go for anterior vitrectomy for how long? And what is the extent? And what's the limit? You should remove all the central part in the posterior axis. And you should be very near to the edge of the posterior axis, even going under it. Why? And here at 12 o'clock, going at 12 o'clock directly forward. Why? Because here, 4 years after surgery, can you see this is the anterior axis, posterior axis, and these are lens epithelial cells growing over the anterior vitreous space. Despite performing posterior axis, because there is inadequate vitrectomy. And here, inadequate vitrectomy in this part. Here, inadequate vitrectomy. This is 5 years after surgery. This is posterior axis and lens epithelial cells. Despite performing PCC, there is lens epithelial cells growing over the vitreous. Here, 8 years after surgery, with a perfectly rounded posterior axis, and lens epithelial cells stopped here. Why? Because we did a very good anterior vitrectomy. Another eye, 8 years after surgery, can you see how severe the lens epithelial cells? But with perfectly clear visual axis. Even when the posterior axis is small, if you go for a good vitrectomy, you're going to have a perfectly clear visual axis. IOL implantation. Inject viscoelastic inside the capsular bag from the two sides, and the IOLs we're going to use is hydrophobic acrylic intraocular lens, and I use the AcrySoft, which is the best. We fold it and then introduce it inside the eye with the help of the cystosome here. The lower haptic is placed inside the capsular bag, rotate the IOL and leave it to unfold. The second step, introduce this haptic optic junction in the bag. Push it until it is inside the bag. And then, with the help of a fork, this is a very important instrument in pediatric cataract surgery, we will hang the haptic optic junction and then rotate the intraocular lens until it is inside the capsular bag. Usually there is elongation of the rexus in the axis of the haptics when we are implanting below the age of 2 years. There is elongation. However, it is perfectly rounded if the baby is above 2 years of age. And this is another eye and conclusion of surgery. But sometimes, when we go for such a thing, okay, there is another technique to implant the upper haptic. You hold it with a fork here midway between the edge of the upper haptic and the haptic optic junction and push it until this is inside the bag, and then push it forward and leave it. Now the IOL will be inside the capsular bag. So this is another type of introduction of the AcrySoft. If we did such a thing, and then we push the IOL and we tried to push, but the haptic actually, we tried to leave it like that, and it came to be into the anterior chamber. What we do? We're going to rotate the IOL, and the haptic is placed inside here, the anterior chamber, until we get it up here. All the IOL inside the capsular bag, How can we get the up one here? This haptic, we will catch it with a dialer and then pull it forward, pull it, pull it, pull it, pull it, pull it, and we leave it when it is under the anterior axis. Now the IOL is totally inside the capsular bag. Another case, we pull it until we are sure that we are under the anterior axis. We try to leave it, and now the IOL inside the capsular bag, despite having two large anterior and posterior axes. And sometimes we use the one-piece Acrysaf. We inject it inside the capsular bag to be implanted between the anterior and posterior axes. And this is the multi-piece and single-piece intracarotis. Few days after surgery, the single-piece and multi-piece. Few months, then the epithelial cells start to grow in the single-piece and in the multi-piece. And few years, we found that the multi-piece is actually accompanied by less density of lens epithelial cells. And in older patients where we leave the posterior capsule intact, definitely posterior capsule opacification will develop, and in these cases we go for YAG laser capsulotomy to clear the visual axis. So the posterior axis, finally, the posterior axis is indicated in infants below the age of 2 years, mentally retarded patients, whatever their age. As this man is mentally retarded, I should treat him as a baby. See, he's crying during surgery. Down syndrome, I should go whatever the age, I should go in the teens, in the 20s, in the 40s, I should go for posterior axis, crying at the time of surgery. And if the child is outside your city, I should go for posterior axis, because if we leave the posterior capsule intact, it will be like that. And there will be marked amblyopia and very dense posterior capsule opacification. Or this child is 16 years old, I will go for posterior axis, because I'm sure that they are not cooperative and they will not be able to come to me again in the follow-up. I should go for posterior axis. Lastly, the postoperative care. Immediately after surgery, the eye should be patched with the eye shield. We remove the patch 1 day after surgery, but the eye shield should be on an eye for 2 weeks. We go for a combination of antibiotics, steroids, cytophagics, and beta blockers, tapered around a period of 1 month, and take care that the topical steroids is very dangerous. These babies may develop Cushing syndrome from the eye drops. Can you see the plumpy babies like that? See how severe it is? And sometimes it is marked severe like that, so you have to monitor this with a pediatrician. This is after surgery with a Cushing from just the eye drops. Here before and a few months after stoppage of steroids, and a few years after surgery. And in cases of bilateral aphakia, we fit the baby immediately with aphakic spectacles, and we change these spectacles every 3 to 4 months, because the eye grows during the first 2 years of life 80% appearance, and you should choose the right frame for these infants, and this is the ideal frame. All plastic, hypoallergenic, it doesn't cause any allergy on the face of the baby, and it should cover the eyebrow like that. It should be large and fitting perfectly at the nostrils like this. And there are special designs for the infants if you go for surgery as early as few weeks old. And now we have the advantage of lenticular intraocular lenses for this microcephalic baby. See, this is a thick lenses, but with the lenticular lenses, it's very thin and it's not heavy and possible to be fitted easily. For children with bilateral pseudophakia, we fit them with the bifocal spectacles for near work, and we add +2.5 diopters. For unilateral cases, we go for amblyopia therapy. At the beginning, there is resistance. See that children are crying and they are not actually accepting. But with time, their sensory esotropia, they accept the patch and they proceed the amblyopia therapy. As in this child, for example, it was very successful amblyopia therapy. Proceeding with the amblyopia therapy immediately after surgery. Here, 6 months after surgery, with the glasses on. 1 year after surgery, having straight eyes. 2 years after surgery, with straight eyes. 4 years after surgery of the same patient, again with the spectacles and maintaining straight eyes. As we said before, the Down syndrome, exotropia immediately after surgery with good amblyopia therapy, and here 2 years after surgery. Another child who had cataract surgery at 6 months old, now maintaining clear visual axis and straight eyes with good amblyopia therapy, and now he is 8 years old with again still straight eyes. But for how long are we going to go for this patching? Until the child is 9 years of age. You should ensure that these patches are hypoallergenic. We get them from Germany, especially for these children. Otherwise, they will not actually accumulate to go for this patching. And we get them special charts for amblyopia therapy near work in order to, it's a sort of entertainment at the same time in order to encourage near work. And you have to ensure very long-term follow-ups. This is a baby done surgery at 40 days old, 2 years after surgery, 6 years after surgery, 8 years after surgery, and going to a school of the normal children. So cataract is one of the most preventable causes of preventable blindness. And another baby with sensory exotropia at 9 months old, immediately after surgery, with amblyopia therapy, straight eyes was achieved, here 8 years after surgery with straight eyes. Finally, to conclude, since we have very high rate of pediatric cataract in Egypt, there should be main guidelines to follow while diagnosing the case of pediatric cataract. You should go for systemic evaluation to know the etiology of this cataract, and there may be a great variety in indications of surgery and the choice of intraocular lens power and the choice of surgical technique. So every single case represents a unique challenge, and you have to tailor your surgery accordingly. You have to go for the early diagnosis, as we said. You have to provide the suitable surgical technique and ensure long-term follow-ups, because complications may occur years after surgery, and you have to ensure compliance of the parents with the treatment and amblyopia therapy, because you may go for a wonderful surgery and you're going to go for amblyopia, it's going to be useless. Aiming at the end and seeing these beautiful smiles on the faces of the infants and children when they are no longer handicapped after pediatric cataract surgery. And thank you very much for your kind attention. I'm sorry for being too late. Thank you.
ممنوع لكل
بالنسبه للبايومتريك الاطفال اللي هو لو احنا ما عرفناش انها في ريدنجز واحد من البايومتريك للاطفال عشان لو ما عرفناش نعمل ريدنجز
ولا معانا